finally, a source of raw, real, and honest information on healthcare issues that matter most. Welcome to BS Free MD. From the latest medical information to how to stay sane as a doctor or a patient, no subject is taboo, no BS is allowed. Now, let's welcome your hosts, Doctors May and Tim Hindmarsh.
All right. So we are delighted to have Dr. Harvey Risch with us, who is now Professor Emeritus at Yale. That's apparently a fairly good school from what I've heard. And
did you go there?
No, no. But interestingly, I had a cousin who did research there. He is the foremost authority on what's his name? Newton, the anti-slavery ship owner who wrote Amazing Grace. But that's a complete bunny trail.
And
anyway,
yeah, you're good at bunny trails.
I am very good at bunny trails. So we are going to bring in Dr. Risch.
It's been a couple of years. Welcome back. I was looking up to see what episode that was, 25, for people that want to listen to that episode again, that you were on June 23rd, 2021. How things have changed since then.
The more they change, the more they stay the same.
Yeah, right.
Well, and it is. And it's really interesting because that episode we called Follow the Herd. So we were both kind of assuming, all three of us, that the vaccine that was, being distributed at that stage of the game, out for several months, was going to bolster herd immunity. And we went through all the details of what herd immunity means. And, because we actually follow the science, well, it didn't turn out that way, did it?
Well, yes and no. Mostly no. A little yes, but mostly no.
Yeah. And so, I mean, I actually like going back and seeing what we have discussed in the past and seeing how much it changed as data changed, because I think that that's critically important. And I've always held, I reserve the right to be wrong, because none of us have perfect knowledge, and we're just trying to flesh this out and do the best we can for people, help our patients, and so forth. So let's move on from there. I know you've been talking a lot recently about the co-op, basically how pharma has essentially co-opted or bought most of our scientific institutions, etc. Can you elaborate on that for us?
So I think that, pharma is very predatory, and I think they've used two techniques over the years. One is to throw infinite money out there to command obedience from everything, from the medical system, from the medical journals, from regular media. And they do this because think about what it takes to develop a new drug, a patent drug, say. So you're going to spend $1 billion to do the scientific research to get one that's likely to be successful. And that costs that much because for every one you find, there's hundreds that you've tried that didn't work. And then you spend $2 billion marketing it around the world to get people to take it. And then you make $30 billion on the drug. Meanwhile, you escrow $4 billion for the lawsuits that are going to happen. And so you've got a net of what, 25 billion that you've made through this process. And then you move on to the next one. And so this is the cycle, the pharma cycle, how they make money and what they know they're up against. And so they, with $2 billion of marketing, they can pretty much control all the narratives around everywhere that become obedient to their funding. So that's the first way that pharma controls this. But there's a more insidious way that pharma has controlled this, which is to promote a narrative that only the studies that they are the only ones, by and large, who are able to fund to carry out, convey medical information supporting medications and vaccines, for that matter. And that's the randomized controlled trial dogma. This started in earnest in 1991, when the term evidence-based medicine was used to define a branch of clinical trials research that was supposed to provide legitimacy as a separate field. But to me, as an epidemiologist, then I was totally annoyed that they thought this implied there was no ever medical evidence before 1991. So the whole canon of medical literature that had occurred since ancient times was now somehow not evidence-based, and we should throw out all those medications because they weren't evidence-based. And now we're going to first do so-called evidence-based medicine. And what they thought evidence-based medicine was exactly was not defined, until finally David Sackett, who was one of the creators of this discipline, in 1996 finally defended it in print, where he said that this is the strangest definition I've ever seen. If you ask what's physics, well, give me a definition of physics. I could give you a definition in one or two sentences. But so what he said is evidence-based medicine is good doctors use the best available evidence along with their clinical experience. And this is so anodyne as to be almost meaningless, but it's basically wrong. It's basically misrepresentation of what science is about. That the best available evidence is a cherry picking system where you subjectively weight studies that you like and subjectively downweight studies that you don't like in order to make the case that you want. It's a cherry picking system. Objective science takes all relevant, valid evidence and has to make a case for what you're interested in, come hell or high water. I mean, you have all the studies, and you have to try to make a coherent sense of them, some supporting and some not. And we've been doing this for forever in epidemiology and science, and this is the general way that science is done. And so this misrepresentation has led the field to think that the best available evidence has somehow converged on randomized trials, because randomization cures all scientific ills, right? Well, this is a plausibility argument that I said, it has true believers, like most doctors who are brainwashed in medical school to think this. But randomization works to a degree. It's not a question of whether randomization works, but how well it works. And that question is never addressed. It's always said it's black or white. You randomize, you're home free. You solved all potential bias and confounding problems in studies. You don't have to measure anything else on your subjects. You just have to randomize them and then look at the differences in the treatment groups. And the problem with this is that randomization benefit doesn't kick in until you have large numbers of people in the outcomes of your trial. So, as I say, if you flip a coin 10 times and you get 7 heads and 3 tails, that happens by chance, or the opposite. That happens by chance about a third of the time you flip a coin 10 times. But 7 over 3, that's a factor of 2 of bias. If you really think that if it's a fair coin, it should come up 50-50, right? And if it comes up 7 over 3, it's a factor of 2 away from 50-50. That's a big difference. And that happens by chance because you only flip 10 times. If you flip a coin 100 times, the chance of getting 70 heads out of 100 is minuscule. It's like 0.00002 or something like that. Doesn't happen. But it's the same 70 over 30, the same factor of 2 or so. It's the same bias, but it doesn't happen with 100 flips. Can happen with 10 flips. And that's the problem with randomization. You need like 50 or 100 people in each outcome group of the trial in order for the randomization to work well. Without that, it doesn't work well enough to make the randomization do anything. And of course, because you didn't measure all of the other things like age and comorbidities, chronic conditions, and degree of illness of the patients in the trial, and all these things, you didn't measure them. Or if you did measure them, you didn't adjust for them in the analysis because you thought the randomization cured that and you didn't have to. So this is why randomized trials can be good if they have large numbers of outcomes, but most don't. And for example, what we're told is the big trial of the Pfizer vaccine, 44,000 people. Is that a big trial? Think about how much money it takes to randomize and follow up 44,000 people on a vaccine. But the trial itself had 162 infections as the outcome in the control group, in the placebo group, and 8 in the treatment group. Okay, well, 8 is just not randomized. That's fewer than 10. That doesn't count as randomized. And that's the problem, that this trial is bandied about as a large and definitive trial, yet the randomization was almost useless, and there's no adjustment for potential confounders that could have been associated with those outcomes.
Well,
So I have to ask for the people that listening to our show that are non-medical or scientific based, which is a lot of them. So are you saying that in order to have a good randomized controlled trial, you have to have outcomes of at least 100 or more, no matter the population that's enrolled in the trial? Would that be a fair statement?
Yes.
Okay.
At least 50 in each of the treatment groups. Yes.
Right. But you can't predict what that's going to be based on how many people enter the study,
Oh,
which
you
we
can.
saw. You can?
Oh, yeah. And the reason you can is because normally randomized trials are designed, you basically, the investigators guess what the benefit of the drug would be. So say it cuts mortality in half. So that's a twofold cut. So with that number, you can guess, and in fact, estimate the number of people that go into the trial in order to have a 90% statistical chance of seeing that twofold cut. Okay, so that's all standard stock statistics that we do, everybody does, to know how many people you need in your trial.
Mm-hmm.
The trouble is that the trial isn't defined by it. Instead of that twofold benefit, it should be defined by having enough people so the randomization cut the bias down to 10% or less because of unbalanced people in the outcome groups. And that generally is much larger, and they probably would have had to do 4 times or 5 times the size of the trial in order, if it had turned out the same way, in order to get to 50 people in the smaller outcome group, in order to make it randomized. And they didn't define it that way because they didn't care about that, because that's not in the consciousness of evidence-based medicine, as it were.
So I remember this. I know exactly where I was, because it was almost like the Kennedy assassination, which I don't remember where I was because I was negative 2 years old, but that's besides the point. So I remember I clicked on whatever it was, the press briefing, and they said, 43,000 people in the study, or 44,000. And then I looked at May. We were on vacation in Clearwater, Florida. And I said, they only have 170 total infections, and there's only 8 in the treatment group. And I said, this doesn't mean anything. And I figured that out, and I'm a dopey country doctor wearing a Megadeth sweatshirt. So I'm sitting there thinking, and so I actually emailed a former colleague of mine who had worked at the state of Oregon, doing formulary stuff and evidence-based whatever. And I said, how does this have any meaning? Like, this doesn't make sense to me. There's just not enough people in in either side. And the response was, I never got an email back. So,
but I guess to my
you were
point,
censored.
yeah,
yes.
you were
But I'm sitting there thinking, how come nobody else was freaking out? I remember Peter McCullough, when we interviewed him, that was May of 21. And he was like, well, there was only 10%. I mean, the best you can get is 10%, because, only 100, was basically at 10% or 5% or whatever it was of the people that didn't get vaccinated got COVID. So it didn't really matter. I mean, it's essentially
1%.
Yeah, 1%. Yeah, that's what it was. Yeah, right. 1%.
So back to the number, because I'm going to try to simplify this for people listening that are already confused by the numbers. So if they enrolled 44,000 people, and on the one side you only have these 8 people getting infected in the one group, how many more people should they speculatively enrolled to get higher outcome numbers of 100 infections on that side?
Well,
do they know that? I mean, could you calculate that?
I would multiply by 6. If you made it 6-fold as large, then you'd have 6 times the 162 and 6 times 8. So that would be 48 people. So close enough.
So literally,
Okay.
So that study should have been 300,000 people.
Yeah, that's right.
And what you're saying is, you, as epidemiologists, know basically, or have a good guesstimate based on what's happening with either the drug or the population, and they should have been able to do that before the study started. Is that right?
Correct.
Okay.
So then, how did this get through the FDA? Like,
Exactly.
I mean, it's clearly captured by pharma. I mean, because this isn't. I mean, this is kindergarten level epidemiology, isn't it? I mean, this isn't exactly the highest orders of. I mean, our son is an engineer, and he looks at studies because he's an endurance athlete as well, and he looks at stuff, and he calculates the p values in his head basically, and I'm like,
well, maybe they didn't want to have those outcomes, and maybe they wanted to pull the wool over people. Is that part of this? Do you think that's part of what went on? That they just purposely didn't enroll that amount of people to get things pushed through and present this false data, or am I just reaching?
So no, I think there's two answers. One is that everybody thinks they understand epidemiology, and nobody understands epidemiology.
Well, I know I don't.
Perfect answer.
And people think that epidemiology is so transparent. You just go get cases and controls, right? What could be easier than that? Who needs to know anything? And the problem is, and so I've taught advanced epidemiologic research methods to our PhD students before I retired anyway, for 30 years. And for the last 10 or 15, the first day of class, I would ask the students, so these are students who've already had a year of epidemiologic methods coursework. I'd ask them, what's scientific about epidemiology? And they would kind of realize that nobody had ever asked them that question before, not quite know what scientific means, although they should have by now. And then they'd say, almost always, person, place, and time, which means studies of the descriptive information about a population, an exposure, or an outcome, things like that. And I'd say, well, no, that's descriptive. There's nothing scientific about that. Scientific means analytic. You want to find a relationship from something to something. And so then what's scientific about epidemiology in that context? And they had no clue. And I don't blame them for having no clue, because before I did that, I Googled the scientific basis of epidemiology. And there's only one reference that comes up, which turns out to be a PhD thesis from the University of California, Berkeley School of Public Health, done in the 1970s with that very title, The Scientific Basis of Epidemiology. Wow. And so I put in a request, interlibrary loan, to get a copy of that. A month later, I got it. I read it cover to cover, this PhD dissertation. And it is a complete history of epidemiology that never addresses the question of the scientific basis of epidemiology. So, I thought, and I had already been thinking about this, and the answer is, and the question is salient, because what makes epidemiologists different? What is the expertise, the knowledge base that we use that's unique to epidemiology, that's not genetics, clinical medicine, biostatistics, law, or any other discipline? And the answer, or demography. And the answer is that what we're interested in, the problem that we have as epidemiologists is we can't study an entire population. Populations are too large to study. So we take samples. We sample the population. We sample people with the disease. And the essence of it is that those samples have to be representative of the population and the disease, because we don't want to talk about our study shows this in the study people. We want to say the disease works this way, and the disease works this way in a whole population. So the point of epidemiology is to say that we use sampling methods to study samples of individuals in order to draw representative conclusions that generalize to whole populations and to whole diseases. That is the scientific essence of epidemiology. And for this reason, you can understand why epidemiologists agonize over bias and confounding, the factors that distort the associations, the magnitudes of the associations that we see. And that's our bread and butter, is to agonize over this stuff, to worry about this stuff day in, day out, and estimate how big the problems are and all that stuff quantitatively. That's what we do. So the first part of it is nobody understands this, and nobody understands that randomized trials don't solve this problem at all. And therefore, the issue of why isn't anybody paying attention to this is because nobody knows they have to be paying attention to it. Everybody thinks they understand it, but they don't, because they don't even know there's the problem here.
Yeah, it's
wow.
just,
So I guess my simple
man.
little brain thinking that, and you can correct me if I'm wrong, is that with randomization, you hope to, people think, well, you're going to split the healthy from the unhealthy, or the people that with this disease versus people without that disease. But there's so many there's so many other little elements that could influence their health or that disease that you can't control, whether it's diet or what's floating through the air, or where they work, or their social factors, or so many things that is so different in everybody's lives that it really will warp the results in a way that you have to sort of separate out those, and there's just too many to account for. I mean, does that make sense?
Yes and no.
Okay.
So, in 1980, that would have been true, that medical knowledge for most chronic diseases was not that well established. And so there was a claim early in that period that randomization, so if you measure something, you can always adjust for it in the analysis of a study. So the only benefit of randomization is you don't measure everything that you needed to. And so you don't have to adjust if the randomization is good, because they're balanced. Whatever those factors are that you didn't measure, they're balanced anyway between the treatment groups.
Okay, makes
Now
sense.
comes along 1995, 2000, hundreds of thousands of studies on the etiology of every chronic disease and infectious disease and whatever. Now the medical literature is filled with knowledge about risk factors for these diseases. And so now we have medical studies that are basically measuring these non-randomized studies that are measuring everything in the world that the investigators think is relevant for the particular disease. And once you measure all of that stuff, you adjust for it. And so the non-randomized studies that are adjusted for all these factors basically understand the disease better than the randomized ones that don't measure or don't care about those things. Could something slip by? Yes. But in general, investigators know that if there are any big ticket items like cardiovascular disease and smoking, or some, heart attacks and smoking, they're going to measure smoking in order to do a study about myocardial infarction, heart attacks. So in general, the measurement of relevant factors of non-randomized but controlled trials is quite good. And that's why these studies today are every bit, on average, the equivalent of randomized trials. And in fact, the Cochrane Commission library, which is the big meta-analysis consortium in UK, commissioned a review of the comparison of randomized trials compared to the non-randomized corresponding controlled trials. And so this is thousands of studies that were compacted into, I think, 14 meta-analyses. And those meta-analyses were meta-analyzed to show an 8% average difference between the randomized trials and the non-randomized but controlled trials. So empirically, we know that today, with modern knowledge in medicine, that non-randomized but controlled trials done well provide the same equivalent information as randomized trials.
Okay, that is a critical piece of information, like critical, because I think as I've crawled out of the swamp of corporate medicine and drug reps coming to the office and all of these
presenting their sheets,
all of this kind of stuff, and it was always the randomized controlled trial was the key standard. And that was the gold standard. And I sit there and I go, okay, well, why is that the gold standard when you're saying that there's other ways to look at things? And I'm like, is it because the only people that can pay and afford to do the randomized controlled trials are these gigantic pharma companies with billions of dollars to spend on drug development? Is that what it is? I mean, it just it keeps it out of reach for, smaller businesses, smaller companies, smaller, universities, etc.
Well, I think that's true. I think that was the impetus for defining evidence-based medicine, that the pharma realized that it had a tool to use among the various tools, some less savory than others, to be able to control the narrative about their products and getting them through the regulatory process and so on. And so they took advantage of every method they could use to push their drugs, their vaccines and everything. And it was kind of the government regulatory side to push back. That's why we have the clinicaltrials.gov database to register all the trials, so that pharma can't do 10 trials and pick the best one and ignore all the others and claim that it's representative of how well the drug works. Why they have to define the outcomes of trials before they carry out the trial, and why they have to stick to those outcomes. remdesivir trial notwithstanding. But
Well,
so I
yeah,
remember,
oh.
I remember this perfectly because we were in a residency in 91 and 92. I remember being hit over the head, having to do these journal club thing. And it was all about the evidence-based medicine was, you bet, the talking word for us during that time. And so it was like, oh, everything we, do in med school now, it's this evidence-based practice type of thing, which we went forward. And then as time goes on and more in practice, I remember like we would get these randomized controlled trials and the drug reps would come in and I'm like, yeah, but I'm seeing different stuff in my practice and talking to other colleagues. And I'm like, so what? Everything that we see doesn't count. I mean, I think within the first 5 to 10 years, I was starting to question that. So these randomized controlled trials show that this doesn't matter. This doesn't happen. But I'm like, but it's happening in my practice. So what does
don't
that
believe
mean?
your lying stethoscope.
Right.
Yeah,
No, but that's exactly
exactly.
it. And you were really the first person to kind of burn the scales off my eyes with that when we spoke last time, which was
You're slow.
You're slow. Well, no, but that whole business with, you were talking about hydroxychloroquine and how that kind of was the light bulb moment for you with regards to that, something is afoot with all this COVID stuff. And people are seeing something with their own eyes and they're denying that actually happened. And I think, what, May reminded me, but, they'll bring it, they're coming in and they're detailing you on lisinopril, right? 25 years ago, 30 years ago. And we see all these people getting a cough from lisinopril, like lots and lots, like damn near half. And they're like, well, no, it's less than 5%. That's what the trial shows.
No,
and I'm like, no, it's not. It's
8 out
like,
of 10 of my patients seem to have a cough.
It's just, it's like, yeah, it happens all the time. Well, then of course, once it's off patent for God knows how long, well, then, they bring out the ARBs. Well, what's the advantage of the ARBs? Well, you don't get the cough. Well, I thought no one was getting the cough anyway. And you just, your head explodes.
Yes. And that, it just on and on and on. And even, into then COVID findings with treatment. And it's like, funny, but if we're doing this and this with these patients and they're getting hydroxychloroquine or they're getting their horse paste from the feed store and taking it in the calculated doses, they're doing okay, but somehow.
So the real issue here is that you in practice were able to do what you wanted and for the best of your patients in spite of a lot of this other stuff going on. The problem has been, in my opinion, when corrupted medical societies make consensus statements that are really only recommendations. And in fact, they say they're recommendations, but they use inflammatory language in those recommendations in order to compel people to follow them blindly as if they're policy or law in medical practice. And that happened, in fact, with hydroxychloroquine. And this gets to your points that we were discussing before we came on air about the difference between relative risks and absolute risks. And just to refresh, that hydroxychloroquine can have a very rare outcome, adverse event of torsade de pointes, which is a cardiac irregularity that, if it happens, has approximately a 20% mortality. And it can be reversed if it's detected in a patient, usually in a hospital patient, but it's still a significant thing. So the question is, how much do we worry about giving hydroxychloroquine to somebody if that could be a possibility? The answer for some docs is, well, let's do them a screening EKG and seeing if they have any risk factor and a predisposition to this adverse outcome to know whether they would really be at risk or not. And then that will reassure me and the patient that we can proceed. The answer to that is, well, that's not exactly how this all went down for the first 65 years of tens of billions of doses of this.
I know.
It was just given willy-nilly and assumed to be safe, and it was safe for virtually everybody. So what reconciles this problem? So the answer is that the Cardiologist Society, I forget the exact name, did some analyses to find that hydroxychloroquine in whatever daily doses increases the risk of torsade de pointes about tenfold. Now, etiologically speaking, relative risk is a measure of the etiology of something. In other words, when you're asking the question, does this drug cause this outcome? A large relative risk is a strong piece of evidence that it causes it. Okay, so a relative risk of 10 says, yes, this drug causes this cardiac arrhythmia. That's the first question. The second question is, what does this mean? And the what does this mean question is, how many patients would be affected by this? And the answer to that is, well, just because it increases the risk tenfold over what? So you have to know what's the risk of this in daily life without this exposure. The over what, the baseline, the what that you have to increase the risk tenfold over. The answer to that is something like 1 in 10 million, 1 in 5 million.
Right. It's like you're prescribing something and then they get the leaflet or they watch the commercial on TV. They're like, well, I don't want to take this because it says that I can get cancer or lymphoma or anemia. And I'm like, yeah, but the risk of that is so minuscule compared to the benefit of the medicine
that's not for the patient. That's for the drug company to get off the hook saying they've informed the patient and the doctor. But so if you've got something that has a baseline risk of 1 in 500,000, 1 in 5 million, and you multiply that by 10, the tenfold increase in risk, you're still talking about 1 in 500,000. It's still so rare that you would never pay attention to that. But everybody was freaking out over the tenfold relative risk, which is absurd. That's the problem.
And honestly, I mean, I was on hydroxychloroquine for my rheumatologic condition. Do you think they even asked about cardiac? I mean, worried about that? Was there screening? No, have we had patients in the past go to rheumatology and it's like, oh, same thing with people. I see prescribers throw clindamycin like left, right, and center for an ear infection and the risk of like getting C. difficile is so huge, but probably a lot higher than Torsad the point from hydroxychloroquine. But do people ever consider that? And so that whole thing brought up regarding the hydroxychloroquine was just frosting me because I'm like, honestly, yeah, what is the relative risk compared to all these other things we do in medicine every single day and not consider it?
You know, during my session of massive quantities of coffee and reading throughout the last 3 years, I came to the conclusion that regardless of what side you're on, if they don't give you absolute numbers, then it's just deception. You know, if it was, there's a 30% reduction in whatever, it didn't mean anything to me anymore. Like I told patients, we did it on the podcast. I said, they can give you a percentage, but they have to give you a percentage and the absolute numbers. Because, because otherwise it's just deception.
Right. Because if there's only 10 people you're comparing and there's a 30% reduction, that's 3 less people. But if you have 100,000 or 1 million people and there's a 30% reduction, how many people? I mean,
so this is the difference between a 10% increased risk of breast cancer, versus a 10% increased risk of, I don't know, say pancreatic cancer. That breast cancer is tenfold or more frequent than pancreatic cancer.
Correct.
And so a 10% increased risk is a large number of women.
Right.
If 10% of women get breast cancer in their lifetime and you increase that, just think of how many women there are in the population, 100 million, 150 million women, 10% higher than that is a big chunk of numbers. Whereas if it's a small number and you raise it 10%, it's kind of meaningless.
Exactly.
Right?
And that's what people don't get. They just hear the numbers and think, oh, 10% more.
Yeah, the classic one was the back to sleep program.
Oh, yes.
Where you put babies on their back to sleep when they're infants, and it cuts crib death in half. And so I remember May and I had this debate because our son would not sleep on his back, like at all, to save his life. And then I said, look, May, the incidence it goes from something like 1 in 500,000 to 1 in 250,000. So it's a massive relative risk difference, huge. And I looked at her and I said, with our infant child freaking out, I said, look, a 1 in 250 chance of SIDS is way better than a 1 in 60,000 chance of homicide. So he's going to be sleeping on his tummy and he's going to be just fine. And but patients would just like their kids would have flat heads from sleeping on their back, like all these outcomes. And you kind of,
I know ours did, but it resolved.
yeah, exactly. And it's like, look, it's an intervention that doesn't have any downside risk other than a bit of a flat head. So whatever that it's that part's fine. But then you get into, any
Well,
other
the flat face part would be worse.
Yeah, that's true. That's true. Unless you're into pugs, in which
Right.
case it's perfect outcome. But
You're still sleeping on your face.
no, I'm still sleeping. I'm one of 10%,
I
and
said yes.
it drives her completely crazy. She's like, I don't know how you're not dead.
I don't know. I trained myself to learn to fall asleep on my back.
Me too. Yeah.
I'm going to have to do 5D meditation. We talked to a guy yesterday. He told us to do that. I think that's my only hope. But
now we don't have. Now it's no longer SIDS. It's SADS.
That's right.
well, right. And
Okay,
that's
let's
let's pull that string of yarn. And that's the thing. That's the other thing. I had a conversation with somebody, I can't remember, the other day. And I said, look, this stuff is, I thought for sure what was going to finish the vaccines off was going to be a university student. They're going to mandate this. You're going to have, the captain of the football team from a large university, and they're going to have a terrible outcome or die or something,
like on national TV.
Yeah,
in front of them.
exactly. And then they're gonna there's going to be a suit, and the Brinks truck gets backed up, and the coffers get emptied, kind of like the Jerry Sandusky thing when all these kids came out of the woodwork as soon as they knew they could get money from Penn State, blah blah blah, and then the vaccine would be finished, and it would be a series of lawsuits, and then there's just all of these instances, people on camera, like just collapsing, and then 10 million people watching Damar Hamlin. And like, I get it. We don't have absolute knowledge of what happened, but I mean, come on, this is a massive signal that something's going on.
Yeah,
and it's like nothing happened.
No, they died from coincidence.
Exactly.
Right. And then across the border, I remember we talked about this because we're from Canada. It was in Alberta that it was published at one point last year where they had a month in the news. It said there was the biggest number of deaths, instead of it being heart disease, stroke, cancer, was cause unknown. And so they were reporting that, and like, how in the heck can the biggest sector of cause of death now not be?
Yeah, the number one cause on death certificates in Alberta for this, I don't know how many months, was cause unknown.
Well, that's not actually honest. It should have been cause uninvestigated, cause not investigated.
There you go. I like that.
Exactly. And it's just, it's just beyond it. It's beyond. I don't get it. Like, are people just so burned out on all of this that they just don't want to look anymore? And it's just,
or do people really want to believe the narrative that they believe and keep ignoring the signals and the truth because they still want to hang on to the belief system?
I think that people who've managed to somehow get through this relatively unscathed just want to get on with life, and they don't kind of care much about everybody else. People who have been hurt or their family members have been hurt by this want some acknowledgement of that. They want some justice for the people who perpetrated this on us. And then there's the contrarians among us who said this has been going on all along. And of course, we're not going to settle for non-apology apologies. And, this was a nefarious involvement of agencies and interests that need to be rebuked, legally in court and financially.
Well, but then they do surveys. This is the other thing that just drives me crazy. You read these Rasmussen or whatever surveys, and it's like, the majority of the population doesn't trust any of these entities anymore. Any of these three-letter agencies have completely lost trust because deep in their soul, the collective mind of America has got it right. They're like, the FDA is full of crap. The CDC's, giving us terrible advice. I can't trust my doctor anymore. And I mean, I have got, and I said this yesterday, I have gotten far better common sense reasoning from my logging and trucking patients that have zero post grad, like
Not even
some of them didn't
post-grad.
even graduate high school.
Right.
Yeah.
And they figured this out way before the quote experts or my medical colleagues. It's like my medical colleagues are so brainwashed and so entrenched in not losing their job or whatever it is that it's a Kool-Aid guzzling contest. It staggers
there's
the
more.
imagination.
I think there's more. I think that the more education you get, the more theories fill up your mind, and the theories filling up your mind push out the common sense.
Well,
So you believe in theories. People I know,
Yeah.
intellectual people, educated people believe in theories about how life works.
I get it. I can
Right. Yeah, but they don't
extrapolate
actually
that.
live like,
You're right. I mean,
That's exactly
stuff
right.
starts to happen to me. I had a hip replacement 7 weeks ago, and
Oh.
at about week 3, started having this all of a sudden stabbing right lower quadrant pain, and I'm like, and so I'm filled with too much knowledge because I didn't even have to Google it. But I'm thinking, shoot, I'm kind of old for appendicitis, but this is exactly what it acts like. But it's not that tender. No, it must be diverticulitis on the right. I know that can happen. It's happened in patients. So I'm diagnosing myself with this. Even though I'm ignoring the fact that I just had a hip replacement, it's probably muscle spasm and abdominal wall pain and my psoas tight because I'm walking funny. I convinced myself, almost that I had these other things, and that's a simplification, but I have so much knowledge of all that's going on, and I don't remember my rule, which is common things are common, and stick to, well, look what just happened. Whereas anybody else would go, you had a hip replacement, you pulled something, instead of, why would you think you have all these things that don't make sense?
Right.
And I
That's
think you're right.
Right.
Yeah, it is. But I think you're right about having so much knowledge and theories, and you forget just what's in front of you and common sense and
it's
anecdotal, not even anecdotal, but just witnessing what's really going on.
Yeah,
so there's actually another issue that's even larger than this, which goes to the grander scale of the whole problem, which is, to sum up the pandemic in one sentence, our government has been funding research, gain-of-function research on these viruses for maybe a decade. That this was done not only through NIH, routed through EcoHealth Alliance to the Wuhan Institute of Virology and to other scientists in the U.S., Ralph Barrick at UNC, Peter Hotez is another one, and Baylor, who've been doing this research. But also the Department of Defense has been funding this, and to much larger amounts of money. And they $60 million from DoD BARDA, as far as I know. And what happened is, once the virus escaped and created this pandemic, then it became an all costs exercise to suppress how this came about, because in fact this research went on during the gain of function pause from 2014 to 17 that was supposed to have been in order that these studies were continuing, and in their papers they say they were approved by relevant NIH personnel. Now, I don't know whether that was Tony Fauci himself or the program officers for the grants, but we know who those program officers are, and they could be hauled into Congress and asked, did they sign off? Who signed off on these grants during the gain of function research pause? But anyway, so this is what happened. It got out, and they are there now pushing the buttons across society to suppress what's going on, to suppress knowledge, to corrupt through Fauci and Collins the knowledge that this was lab-based, which it was, and that's a whole other discussion we could have if you want some weeds to talk about. But it was lab-created, lab-engineered, got out, perhaps accidentally, we don't know that, got out, created this pandemic. The pandemic was not so bad, but the fact that it's a pandemic is what embarrassed the government and Department of Defense. They immediately took this on as a military problem, not a public health problem. And so they militarized it and put the Department of Defense and the National Security Council in control of this. And that means that the vaccines were not treatments or vaccines, but countermeasures. Countermeasures need not be approved. And what they did is they told the FDA and CDC that we don't care what you do, that we are going to push these countermeasures to protect the population whether you approve them or not. So for face savings, you might as well just approve them. And this is why you see Rochelle Walensky, in profuse sweats in front of the TV cameras, because she knows what's going on behind the scenes. She knows what she's being forced to say as the head of the CDC that she knows is completely false.
Wow. Eloquently, put and explained, because
I usually, when I try to explain that, there's more yelling and more cuss words.
Well, people ask me if I'm wearing a tinfoil hat. I say, what I really want is tinfoil armbands, because that's where the injection is supposed to go.
Yeah, exactly. That is brilliant. Absolutely brilliant.
So, wow, just to go a little further. So do you think that, I think so, and a lot of people, but the whole country then is really driven and by the Department of Defense, sort of as in charge of everything going on, or whether at the governmental level.
Sasha Latapova uncovered that.
Yeah.
I mean, she went into the actual documents, and it's all DOD money and DOD guys working in these, using private companies to do what they're told.
Yes, I think that's where really the top of the food chain is on this.
Yeah.
And I think that it's pretty nefarious. And I'm surprised that none of the agencies would stand up to this, but they haven't. And it explains a bit about why everybody was so locked in to the whole paradigm, and there was virtually no whistleblowers in this whole thing. There must have been some kinds of existential threats to the agencies and to the people that this is national security, national interest. Now you have to remember, Deborah Birx, who was put in charge of this under the Trump administration, was she a lieutenant colonel or something like that? And I forget which agency. She was appointed by Mike Pompeo, who was head of the CIA, who was controlling this, along with DOD. The whole thing was a military-run operation that took charge of it as if this was a bioweapon. They asserted this is a bioweapon. They knew what it was. It wasn't a bioweapon, but they asserted it was a bioweapon in order to have plausibility to take control of it, to pull it out of public health and use the public health people as rubber stampers, as useful idiot rubber stampers.
Well, thank you for saying it's not a bioweapon, because we get some people.
We get a lot of people that are
it's a bioweapon,
convinced.
and great people that I agree with mostly, but then it's it's the depopulation campaign and all that, and I'm not, that's a rabbit hole I'm not ready to go down yet, but apparently we have a lot of UFOs that government admitted, so who knows, right? 10 years from now, who knows? But
it's interesting. Those UFOs have English writing on the side, so I don't know.
Yeah, exactly. But it is kind of.
So
do you think they were worried that it was going to be worse, though? That they knew that they had been kind of playing God with the gain of function, and that maybe it was actually going to be a real bioweapon that got out?
So the answer is, they've asserted, my reading is that they've asserted that the original intention of this research was to create this human toxic virus and then evolve it to be human minimally toxic, but good for immunizing bats in the caves in China to prevent a pandemic from coming out of those caves. Now, I don't know if there's a plausibility rationalization or this is the truth, and it's hard for me to believe when Tony Fauci every year is saying there's a pandemic coming out this year, be prepared. That's just too much to think that this was an intermediate stage that just somehow accidentally got out in the middle. I think it got out, but I don't think that was a rationale. I think they were playing with fire and they got burned, and the finger pointing is completely appropriate for dealing with what these people did and their total disregard of human life in doing this kind of risky work that was during a time when the government thought it was too risky to do.
Yeah, it's interesting because I told May I was reading I think it's the best Substack I've ever read in my entire life. I don't know if you read El Gato Malo, the Bad Cat, and he wrote the today's submission was the biggest lie in the entire pandemic, the central lie, which is pandemics aren't very dangerous. And it was just brilliant.
No, the pandemics are dangerous.
Right, but yeah, right. But the lie is that I'm sorry, yes, the lie is pandemics are dangerous, and in reality, they're really not that dangerous. And then
So actually, it's interesting that I've been talking about this for quite a while. I mentioned it in the Brownstone article that I wrote from a month or 6 weeks ago on plausibility and randomized trials and so on, which is that in almost all of these respiratory pandemics, the case counts do not matter. That the whole premise of a pandemic in suppressing case occurrence is a false public health premise. That what matters is not whether people get sick, but how sick they get. And what you need to keep people from dying, that's the first thing. You need to keep them from getting hospitalized because that's antecedent to dying. So that's the endpoint. And you need to keep them from having long virus syndromes because that happens in all respiratory viruses, not just COVID. So those are from top down, deaths and hospitalization, especially. Those are the outcomes that need to be prevented. All of the public health management goes to those things, not to counting the cases. And so when Guatemala says that this lie was that we have to suppress the cases and so on, this is common sense that has been out for quite some time that we've been talking about.
Well, and I've said it in numerous podcasts. If pandemics were so bad, I mean, human beings have been around for quite a while. We'd have been wiped out a long time ago when we had, cities and no sewage systems. And, like there was way worse stuff to get, 150 years ago. Typhoid and cholera were kind of crappy, literally.
Well, this goes back to the ancients. In the Talmud, there's a discussion of how you tell when infectious numbers of people have constitute a coming epidemic. So this was known to ancients, and it's like human societies have always dealt with this. Some have been worse than others. The Black Plague and has probably been worse at times and has decimated larger communities than what we've seen. I think Guatemala talked about aspirin overdosage during the 1918 flu. That might account for some of it. I don't know if it accounts for all of it, but certainly iatrogenic issues. This has been a plague of iatrogenic damage from the vaccines, in our time, and leads to a lot of other thoughts about the legality of everything that we've done and the balance of protecting the population versus preserving what are natural human rights that we're guaranteed.
Well, and our natural human immune system. I mean, one of the guys that was really in front of this was Bill Maher. Like back, I think it was in 2020, I saw one of his shows and he was just like, you know what fixes this? Your immune system. And I was like, exactly. It's a respiratory virus. It's going to do what it's going to do. It's going to mutate like crazy.
Right.
And, like you think of, you mentioned Cochrane before. You go back and look at the Cochrane reviews on the flu shot. It doesn't do anything.
Right.
And yet, there was this, when was that, 10, 12 years ago when there was a lack of, a dearth of flu shots and, was the president and the vice president going to get a flu shot? I mean, it was just completely insane gilly-lilding that didn't matter.
Right. Well, so, if you look at flu shot efficacy over the last decade, you can see that there's kind of been a systematic decline.
Yeah.
We're saturating the technology with the evolution of the flu, not even excluding the COVID years, that it's been systematically being worse and worse, and at some point we really have to give up on the idea that those vaccines are doing much. And on the flip side of it is that we already knew in 2020 that vitamin D strengthened the immune system. And this is another big suppression thing. Why this was suppressed, I can't possibly imagine. It's not like even hydroxychloroquine or ivermectin. These are things that everybody needs to have adequate levels of, and not high levels, just adequate, in order to keep their immune system functioning well. And why this could not, and it's so inexpensive, why this could not have been a known thing that is recommended. CDC says get sunlight, take vitamin D, and so on. When nobody dies with COVID if they have good vitamin D levels, essentially, virtually nobody.
Yeah, right. And lose weight and don't eat sugar. Right. And there was a million things we could have done that made perfect. I mean, we interviewed two people. One saw what was going on and lost 70 pounds. Another one lost 30 pounds. You know, a young guy, he's like, I'm going to be here for my daughters. I'm not going to die. I'm going to like change my life and be healthy. And it's like, oh my gosh, actually being healthier means you have less risk of death from everything. Who would have thought that? I don't know. My neighbor who's a trucker.
Right. Who doesn't get much exercise driving trucks, by the way.
No.
So I was thinking, so what you said about the flu and where we're at with that, especially now that COVID's happened, I've seen just with patients, friends, a dramatic change all of a sudden where people aren't trusting. They're like, well, I'm done with all shots, even flu shot now, where I used to get it before. I mean, we're seeing a decline anyway, but now people are even questioning childhood vaccines, and that's coming out more. And I guess to take it even further, the drug companies, with all that's been happening and people thinking that they've been lied to, what do we do going forward when patients now don't trust anyone, especially through this pandemic, because they don't know what the truth is? They think everything's full of lies. Obviously, there are very good medications that help people out there, but how are people supposed to discern between the lies? What's a good study, other than hopefully trusting their physician that can make a good decision? I mean, where do we go?
I don't know.
Yeah.
This is a problem. So we start backing up the HPV vaccine, the so-called cervical cancer vaccine, has been very problematic. This is something that I should have read Mary Holland's book about it before we even got to COVID. And then you start backing up from there. Which vaccines are really safe? You know, a vaccine needs to be safe. Whether it's effective is a different,
Right.
but
Right.
it needs to be fundamentally safe because you're vaccinating healthy people. So what
Well,
has
right. Yeah, like the bar for preventive medicine is entirely different than the bar for treating somebody that has stage 4 cancer. I mean,
Right.
they're two, I mean, that's the question. I mean, I read Turtles All the Way Down, and I kind of scratched my head and I was like, this cannot possibly be true. You're telling me that there is not a single vaccine that's used in children in the United States that has been studied against an inert placebo. And I was like, holy mackerel. Like it's really, really crazy. And it's not that the vaccines don't work. And it's not that they, MMR doesn't prevent measles. Like that's the issue. The issue is it's what we get paid for as clinicians.
Is it
It's
causing
risk,
more harm
it's
than
risk
it's
benefit.
yeah.
Have we reached a point now where we try to prevent every single disease? And in doing so, we have traded acute illness for chronic illness, which ultimately may be worse. And the answer is, I don't know.
I don't know. But so the answer to that is more pharma chicanery. That if you're doing a study of efficacy, then you compare it, and there's equipoise. You don't know if the drug works better than the other drug. You compare drug A versus known drug B, right? If you're doing a study on harm, on adverse events, you cannot do the study against drug B because drug B has its own harm. So you have to do it against placebo. If people can't figure out that difference, they should not be in a regulatory agency in the first place.
No, that's exactly it. And it's if like that, I would love to get them on the show, Dr. Abay and I forget his wife's name, Christine Ben, something like that.
Mhm.
And their work is fascinating because they went into, Guinea-Bissau. There was no vaccinated kids. The kids that weren't vaccinated for measles had a death rate like that was 2 or 3 or 4 times what it was in North America. I mean, really fascinating stuff. And they come out and they're like, the only vaccines that actually change all-cause mortality are live. Live measles by itself, live polio, and BCG, which hasn't been on the shores of North America since, I don't know, the 50s.
True. And I remember the BCG episodes when I was in med school. We were wondering about getting vaccinated and not being able to tell if somebody got to TB. So
Right.
That was that debate. I don't take such a polar view of the vaccines one direction or the other. I agree that there's a lot not to trust. And, there's a lot of motivation not to do new studies of those things. But what we do know is the insurance company databases have information on that. And why would insurance companies pay for things that cost them money? So in general, insurance companies have a much better handle on adverse events than the medical institutions, the research institutions, because the
Really?
research institutions are corrupted by pharma. The insurance companies are corrupted by their profits. And so they really want to know what's in their interest to pay for, right? And why would they pay for vaccination if the vaccinations cause more adverse, whatever it is, that they're going to have to pay for? So they don't. So I that's how I would look to try to find large scale insurance company databases to look at outcomes.
Yeah, I guess the only thing, I would, the only pushback is if you're talking about chronic illnesses that are distant to the event, that it gets very complicated trying to sort that out. And that's why I have a very agnostic view, because I don't really know. And I kind of agree with Glenn Beck that certainty scares the living hell out of me, because the people that seem to be the most certain tend to be the most evil.
Yeah.
So I'm pretty agnostic.
Are you certain about that?
Yeah, exactly. And so I go, yeah, I think there's more chronic illness, and I think there's more chronic childhood illness. But is it because they're getting 75 shots by the time they're 18? Well, maybe. Is it because we give way too many antibiotics and we're annihilating their gut microbiome? Is it because they're eating way too much sugar? I mean, clearly it's a combination of a whole bunch of things. I mean, that's the only thing that makes sense to me.
Yes, I know. And, I think the problem really is that human nature has its proclivities. And if you pander to it, it isn't necessarily good for people living to old age, healthily. The proclivities from an evolutionary point of view are get those kids out quick and get them to have kids, and don't worry about what happens after you're 40. And so, getting enough calories is because you might not get the next lion to eat for another 3 weeks.
Right.
So, so our evolution doesn't necessarily optimize diets for longevity. It optimizes diets for how we've evolved to get to this point. And so people do what they want to do. And if you put, high fat, pleasurable feeling, tasting foods in front of them, they'll take it because it satisfies pleasure experiences, not necessarily health experiences. And I don't know if there's a way around that to be clever and create better foods that don't, that give pleasurable experiences, but don't come with the burden of worse health. I mean, somebody's got to be creative in that sphere, but I don't know if it's happened much.
Well, clearly Bill Gates' lab-grown meat is
there's got to be a
solution.
way to make good tasting Brussels sprouts. I don't know, cover them with chocolate or something.
Roast them with a little garlic.
There you go.
No, that's true.
I like all the healthy stuff.
So speaking of someplace that our listeners can trust, let's talk about your other job, or I don't know if this is a side gig or full-time job, how you'd want to describe it. I will try to bring this in. Look at that. The wellness company. Tell us about this.
So about a year ago, when Dr. Zev Zelenko was alive, he had been espousing his prevention and treatment with hydroxychloroquine and related medications and supplements. And he was approached by a businessman, Foster Coulson, who proposed to him to set up a company to make his custom designed supplement that includes vitamin D, zinc, I think quercetin, and other things that he called Z-Stack, and sell it. And this actually succeeded quite wildly. And in conversations between Zelenko and Coulson, they came to the conclusion that medical care was so straitjacketed by all the corruption that had been happening by pharma that there needed to be a way of primary care, at least of patients who could be seen without all of the corruption. And that was I believe the spark, the idea of creating a telemedicine company and or supplements that Coulson organized, put backing into, that started about a year ago. And the company has both its administrative corporate side of things and its medical side, which includes me, Peter McCullough, Richard Ammerling, and Heather Gessling, all physicians of one kind or another that are its chief medical board, basically giving it medical advice as to optimal ways of treating patients. We also have a pharmacist, a PhD pharmacist, who is involved in the supplements, creating custom supplements based on the medical literature. So these are not just, oh, well, something touchy-feely sounds good, I'll put it in a supplement. These are, and I'm a supplement skeptic, but I'm a thorough, as an epidemiologist, I'm a skeptic for everything, but especially supplements. But in any event, so they've created some custom supplements that are focused on doing various tasks and have accrued a clinical base of physicians who are aligned with our knowledge base of treating patients according to best medical practices and not according to corporate medicine. And that we went online, I think, in October, and have been ramping up our medical visits to patients as well as supplement sales. And one interesting thing, there's been a big learning curve over this. It's been very effective for the patients that have come to us, and there's been a big learning curve as to how to make this affordable to essentially everybody who wants this. So the cost of primary care this way has been, I think, $50 or $60 for a physician visit, which is, not that much more than a copayment if you're on an insurance plan. And it's face-to-face telemedicine, and we have lab tests available and pharmacies that will fill prescriptions that are written by the docs. And I think we have 48 out of the 50 states covered by this now, and maybe all of them by now. And so this has gone on for a while, and we've had a realization that as much as we're providing medical care through the telemedicine side, we kind of have a business of selling supplements, which has also been successful, but it's kind of a trade-off. Are we really selling supplements, and what do we really want to be selling? And that is health. And so what we've decided to do is a plan. It's starting in a week or so, I believe, which is to offer a subscription package for an individual. I think $199 a month for an individual, or $349 for a family. And what this allows is unlimited physician visits per month and unlimited usage and unlimited amounts of the supplements in a certain way. One month's worth of any of the 15 or 16 supplements, any or all of that per month for the total package. And the idea is that this is something that for this price, and you can see for either of those prices, it compares very favorably to insurance coverage for kind of primary care. And our idea is to try to minimize the amount that you need, because it costs us money to provide the visits and the supplements. So we want to have people try to get, to take them off of unnecessary medications and so on, to promote wellness as best we know how. And I think this is the way it's going to go, that the subscription service is concierge medicine, but it's at a low enough cost that it becomes affordable for most middle class and maybe even lower people to subscribe to. And we have to figure out how to provide catastrophic care insurance, but that will be a totally separate thing. That the primary care is, by and large, for most people, a low-cost endeavor. And when it's included with catastrophic care, then the insurance company prices go so high that it makes it onerous to have to pay $12,000, $15,000, $20,000 a year for medical insurance. That is just a very big chunk of many people's income. And so we're trying to reduce that and make this accessible. And I think we're going to be very successful with that.
That's awesome, because I get, one of the questions we get a lot is, well, where can I go? My practice, I'm not working very much, but I've started doing some primary care again, and patients come in and they go, we listen to the podcast, we like how you think, we think you're maybe somewhat entertaining, and obviously I'm an amazing specimen to behold. So it's been kind of this patient generator, because at least they know they're not going to get beat over the head to take a COVID vaccine, and I'm probably not going to be wearing a mask during the whole visit, especially if they're not comfortable with it. Just common sense stuff. And so it's great to know that there's another resource for people where they,
and in 48 states, I think if people caught in the middle, sorry to cut you off, but for instance, our college age kids who are too old to be on our insurance anymore. You know, hit 26.
Thank the Lord.
But they're not gainfully employed in a place perhaps where they're still in college and school. They're in states where they don't qualify to be on a plan. They're stuck in the middle, or other people have businesses for whatever reason between jobs. I mean, this totally is awesome. The cost, I think, taking $50 for a visit, and you can get, I'm assuming, prescriptions pretty quick. So, you know, you got cut your finger, you got an infection, cellulitis, you need to be seen, and you're not going to get bankrupt by trying to go to a big system that's going to bill you like $1,000 for your hangnail.
Did you see Dr. Attia? He had a post yesterday. His child, they were visiting San Diego, and he went to one of Scripps ERs because his child was sick. And he was directing his wife. I think his wife was there with the family. Right. And, you know, kid was like 6 or 7 years old. And it was like, you know, take him in there. Just make sure he's not too dehydrated. He got a basic metabolic panel, and I think maybe a liter of fluid and a visit. And it was $6,000.
Oh. Right. The opportunity cost, all of that high-tech equipment sitting in there that he might have needed that has to be paid for.
Yeah, like it was completely insane. And I actually commented. No one commented back. I'm like, he could have gone to a hangover drip center in Vegas for, you know, $300 or less, and could have had like the naughty nurse costume woman giving him the IV.
A 7-year-old. That's all we need.
Well, you know, it's
anyway.
No, I mean, so
this is awesome.
Well, what about you know, there's all these primary care clinics that should be able to do this, you know, in a clinic for a lot less.
Exactly.
Primary care should not be done in emergency rooms.
No, and primary care should not be done with insurance. I listened to a really, really good podcast, and the guy said, look, really expensive stuff should probably be salaried. So you don't want surgeons getting paid extra to do extra surgery. You want them to get paid for doing the correct surgeries. So the incentive to, you know, in elective stuff like
doing an extra hip replacement in someone who doesn't need it.
Yeah, right.
That wasn't me, but I'm just saying.
No, but I mean, spine surgeries. There's a lot of stuff that's kind of gray where, you know, and you have to have trauma departments, and you have to have all of these things. But he said primary care should be absolutely free market, because excess would go up like crazy, service would get better, and the cost would go through the floor. Because I just look at our small clinic and the administrative burden of chasing down these claims is crazy.
Right. You're spending more time with the paperwork than you are with the patient.
Right.
Right. Yeah. And then you get into the real evil, which is the metrics, where you get back pay. You know, it's kind of like a car dealership, right? You know, they sell you the car. The guy selling you the car might make $500, but the dealership's making a pile of money if they sign the financing, right? And so you go in your doctor, everyone gets screened for alcoholism, everyone gets screened for depression, everyone gets screened for everything.
Right, because you get paid for it.
Because you get paid to ask those questions
on the car, not just the car.
Right. And you know, I like going to my primary care doctor, getting screened for alcoholism, and getting a fresh undercoating.
Right.
Yeah. So we'll link this website. Is it? Yeah. What is the .com site on this? I'm just looking.
PWC.health.
Got it. Okay. We'll put that in the show notes for sure. How long is, like, for instance, if I was just to click on there, how long would it take as far as a wait time? I mean, do you have to, is it a couple days? Is it immediate? Do you have any idea?
I think right now it's less than 24 hours. It can be same day. It depends on physician availability in your state.
Right.
That we have 50 some odd physicians in practice now seeing patients. And so sometimes there's a lot of evening appointments because these people have normal day job kind of clinical activities. A lot, not all, some of them are older and have quit that and have daytime telemedicine. So there's a whole range, and generally it's been pretty good that it can be within 4 hours, sometimes even less, and generally within 24.
And do you know what 2 states aren't offering it by chance?
It was Alaska and Rhode Island, but I'm not sure if that's still
correct. Okay. Interesting.
Outstanding. Well, this has been great. As we say to every guest, we could talk for hours.
I know.
And maybe someday we will be as successful as Joe Rogan, in which case we will feed you whiskey and marijuana.
I'm sure Harvey wants that.
I just get
By
the sense that-
by televisit, right?
Yeah, exactly.
I'll bring the whiskey.
Yeah, perfect. Outstanding. Well, thank you again so much for joining us. This was really informative. I'm going to be laying in bed tonight, sort of unpacking some of the stuff we talked about, because it's things I know, but you put words around it, which makes it so much easier to understand. So thanks again.
Thank you. Well, this is great. Thank you.
It was great to see you. Thanks for coming.
It's no secret that medicine is a bit uptight. That's why Tim and I created BS Free MD, to mix things up a little and have fun in the process. Besides, we are having these exact same discussions all the time, so we thought we might as well invite everyone to the party. If you really like us, you can get plenty more and maybe see one of Tim's cool tattoos on our Instagram or Facebook pages at BS Free MD. See you next time.
While we try to keep BS Free MD as raw and real as possible, we can't be held responsible for any medical decisions or discussions had as a result of what you've heard on the show. We know, bummer. But the truth is, we really do care about your questions. So feel free to reach out to us by email at doc@bsfreemd.com.